the fifth work group meeting for the assisted living study. Let's introduce who's in the room. So I am Stacy Howes. I am here, and
Ben Steffen, Executive Director of the Maryland Healthcare Commission. Welcome, everyone.
Teresa Lee, Director for the Center for Quality Measurement and Reporting.
and Julie Beard is also here. She just stepped out for a moment. She's program manager with our center. And let's see who is online. Okay, so online we have Ken Lemberg, Catherine Victorine, Courtney Barno, Dan Kaufman, Debbie Gallagher, Howard Solins, Solins, excuse me, Linda Cole, Marsha Boyle, Danelia Bronson, Rebecca Swain Eng, Ruthie Fishman, Ryan Shupp, Stevan Ellis, Shanae, and that is everybody. So welcome. And at the last meeting, we had an interesting meeting where we got to talk to Ruthie Fishman, who is the leader of a small assisted living facility, and she gave us her perspective and the small assisted living facility perspective. And then we also went over a work group progress assessment. And does anybody have any comments or additions about the last meeting they want to bring up? All right, so what we would like to go over today is based on all of the work that we've done together as a work group, we've come up with some recommendations. These are draft recommendations, and we'd like to go over them with you today and get some feedback. And then once we do that, we'll have some open discussion if it's necessary, and then we'll go over the next steps for the work group. Any comments or questions before we get started? Great. So the first slide in the presentation that I sent you is a copy and paste directly from the bill, just so that you have it for your reference. And then these are the draft recommendations that we've come up with so far. And the very first one is we'd like to standardize the definition of small assisted living programs. There is no standard definition within the state or even between states, and we are currently proposing 5 or fewer beds being designated a small program, because that is the wording on the OHCQ assisted living application. What are your thoughts?
So could you just review kind of what, if people are catching up here, what MHCC considers small?
Sure.
And just make sure that.
Okay, so MHCC considers 9 or fewer beds to be small. This was decided at least a decade ago, I believe, and it was based mostly on workload expectations. And OHCQ uses a different definition of 6 beds versus 16 beds, and then larger than 16 is a large assisted living. On their application, 1 to 5 seems to be a small one. So I believe this is where we're coming from. We want to standardize it, and the application says 1 to 5. So we are proposing to call small homes 5 or fewer.
Do we have any data on how many this would actually encompass if we did the 5? If we followed the OHCQ recommendations throughout?
It was half, it was 800. It adds 800. So about a little less than 400 plus 800.
Thanks.
Something in the chat.
Stevan agrees that having a standard definition would be good.
Okay.
So, thank you, Stevan.
Any thoughts on this particular number? Or if everybody's in agreement, you can say that too.
Um,
I
The one
have,
thing-
oh, go ahead.
No, I apologize. This is Stevan. I didn't raise my hand. Is it okay if I say something really quickly, or would you like to, Marcia?
Go ahead. Go ahead.
I just think, the other thing too, and I know all of us know this, but with the assisted living regulations coming out for comment again, and I saw Dr. Nay's comment, that might be something as far as defining terms. Do we mean a regulatory definition or some other definition? And if it's, we want the regulation to have a specific definition, then we'd want to recommend that should be in the assisted living comments when those regs are updated.
Someone else tried to speak.
Hi, this is,
Trisha,
oh. This
Go
is,
ahead,
Marcia.
okay, this is Marcia Boyle. I just had a question. If we do change it, which makes sense, what happens to the assisted living programs that are currently viewed as small, but would no longer be viewed as small? I would imagine there are more regulations that they would have to meet, I understand. So how would that work?
Well, I don't think any,
Well, I don't think the regulations
The
differ
regu-
by size.
yeah, the regulations don't differ by size. So it wouldn't really change any of the recommendations.
Yeah, the only thing that it potentially would force the healthcare commission to do is to rethink, how the facilities that are less than 10 beds, would that a segment of those be included in the MHCC annual survey. Recall that currently, as Stacy said, as a matter of convenience, we do not survey facilities with less than 10 beds. I would note that in conducting the survey, the challenges that commission staff faces in gathering data are inversely related to the size of the facility, with the commission staff spending significant amount of time helping smaller facilities complete the questionnaire. I think this would, if we aligned on definitions, we would likely think about how we would survey facilities from 6 beds to 16 beds, which conforms to the mid-size facility that current exists in M8 and MDH regulations. So we are consistent with those, but I'm not prepared to say what we would do, but I think we would have more impetus for doing a short form survey from the facilities from 6 to 16 going forward, but nothing to necessarily confirm today on that front.
You'll also see as Stacy goes through the recommendations, there are
A
some.
little louder,
recommendations.
Teresa.
And you'll also see as Stacy goes through the recommendations that there is also a proposal to collect information from the smaller ones and different ideas for where we can collect it a little more efficiently.
Right. Dana Kaufman, you have your hand up?
Yes, thank you. So if we're going to standardize the definition of small assisted livings to be 5 or fewer beds, and the work group was on studying the small assisted livings, does that mean that the recommendations 2 through 10 would only apply to 5 or fewer beds?
No, these recommendations would apply to all assisted livings.
The idea is to
You
begin
mean
to
all
incorporate
assisted
the small.
livings? Because the legislation was only talking about the small ones, I think, under 10. So.
Yeah, yes, it was, but as we conducted this work group, we've learned that the challenges are similar across the board, and the goal is to help support all assisted livings of all sizes. So we are recommending these changes or studies for all of them. And it should help all of them improve.
Okay, so that was much broader than the legislation had instructed.
So I think.
Or the
just if I-
participants on this work group were involved.
So I would, my observation would be that, some of the recommendations are programmatic, requiring action by the department or Medicaid. It would be hard to fragment, study on, for example, the community-based waiver program applies to all assisted living. I think if such a study was done, it would be odd to restrict it to small, which of course, should the recommendation number one go forward, it would only be the 5 beds or less, which I think a lot of facilities, but I think if you're talking about the home and community-based waiver program, it could affect, opening that up could affect other large and medium facilities as well.
Right, but just for the record, I'm just going to point out that these recommendations are much broader than the charge that the legislation gave to this work group. And there has then not really been any conversations with those providers that would fall under this now, the whole assisted living industry. So I just, for the record, want to point that out.
Thanks. So noted. I think that's, we would note that.
We have a question from Catherine Victorine that I think we touched upon, but it's the how will the commission treat the assisted livings with 6 to 9 beds? Will the commission expect to survey those facilities with 6 or more beds? And I believe that pertains to the long-term care survey that she's referring to. Allison Siborowski has a comment following on Dana's point. If these recommendations would be for all assisted livings, I wonder if we need a larger set of stakeholders to be part of this conversation.
I think too, the ideal here is that there should be monitoring or regulatory process for all assisted living facilities. And then there was a sense that the smaller assisted living facilities were not getting any attention in terms of our current regulatory scheme. So the idea here is that all assisted living facility programs should be regulated in some manner, monitored in some manner, or addressed in some manner. But we're not necessarily proposing additional requirements on the larger. We are basically here saying that we need to standardize how we define small. And I think you're correct that when we're saying this applies to all, it's because in the end, we want a system that looks at all assisted living facilities regardless of size. But in the first recommendation, we're really trying to address the fact that everyone doesn't agree on what is small and what is not. And for MACC purposes, we've used the 9 or less for public reporting. So we can refine this first recommendation by saying for the purposes of A, B, C, D, if that might help. But that really is what we're trying to get at, is to ensure that all of the assisted living facilities are regulated, monitored in some way. Is that?
I think,
No.
and I think to Dana's point, it's probably good to as we go through the recommendations, if Allison and Dana want to say, let's be clear that I think some of these, as you read through them, they are programmatic recommendations affecting other state agencies. And it would be hard for me to imagine us saying and only focus on the small your additional support, in some cases, oversight in the case of the ombudsman, to narrow it so specifically to the 5 and smaller. But I think as we go through them, if you feel strongly about this, to flag and a particular recommendation and say, let's make that clear that it applies to the small facilities only.
And again, we're putting these out, this is the first view of these, and we're really looking for your feedback to help us refine these things. So this is really helpful. Yeah.
Would you say Dr. Nay has her hand up?
Dr. Nay, did you want to say something?
Yes, thank you. So I just want to clarify again for the group that OHCQ regulates all assisted livings. We don't overlook or ignore the smaller ones. That's not part of our process. That was said at multiple early meetings by other stakeholders, but that's not true. So we go and investigate complaints and self-reports at all the facilities. And so I just don't want that misperception to be carried through to the report.
Thank you. Anna, did you have your hand up or did you put it back down? That's not it down, okay. All right, are there any other comments, suggestions for this?
This is Howard Solomons. Could I just make a observation that when you're talking about the implications of a definition for the commission versus OHCQ, and I know OHCQ is doing an omnibus review of its regulations, I've been searching around for different references to bed counts and their implications. So for example, under the assisted living licensing regulations, there's a distinction based on which assisted living facilities do or do not require a manager based on a 5-bed rule under point 16. And there are bathroom requirement differentials based on buildings with 1 to 8 occupancies, 1 to 8 occupants, and 9 or more. So all I'm saying is it may be useful in thinking through the implications of whatever policy choices are made to bear in mind that there are kind of cut points that differentiate. I know that, for example, for whether or not you need a commercial food service license, I think is based on a 15-bed rule, if memory serves. So, you know, a definition is only as good as the use of it. And I'm just pointing out somebody, if it hasn't been done already, might want to do an omnibus review of the kind of cut points and what the implications are.
Thank you.
Dr. Nay, did you have your hand up again?
Yes, thank you. So to Howard's point, there are cutoffs in the regulations. It's 6, 8, 9, 16 beds. 16 and more is where the food service permit generally kicks in. So those were some of the natural breakpoints that when you look at the local jurisdictions regulations and the state regs.
Thank you. Anyone else? Chats. Yeah, okay. Let's move forward to number 2. Conduct a feasibility study focused on data infrastructure to collect assisted living program data for quality assessment and equitable access across jurisdictions for public reporting. So the purpose of this one is to build data infrastructure so that data can be collected from all assisted living programs. And that way we can publicly report any quality issues. We can also make sure that each jurisdiction in Maryland has accessible assisted living programs, quality assisted living programs, and the number that they need, the number of programs that they need. But we need to build the data infrastructure before we can figure out answer any of these questions. What are your thoughts?
And that's a study, I wouldn't think anyone would object for us in doing the study to include larger assisted living facilities in that study. But I want to hear what people think.
Dana you have your hand up?
Yes, so this one again, as Ben just pointed out, would be all, but I also think it's important because we have the long-term care survey, we have OHCQ surveys, we've got information that is submitted to Medicaid if you're home and community-based services. I don't think it's beneficial to have one more requirement being put on assisted livings to report similar information. I think that there needs to be some language in here that the state needs to look at its own mechanisms for what it collects now and how that can be streamlined and used so we're not duplicating or adding additional administrative reporting requirements.
Yes, that is a good point, and that would be part of this. It's a feasibility study, so we would collect as much information as we could on what we can already do without imposing any more regulations.
Okay, but I think that should actually be written in here too, in the recommendation. I think the state almost needs to audit itself for what it already does require reporting of or data collection.
Okay, thank you.
Rebecca has pointed out that there are additional details in the Word document. If people haven't had a chance to review that.
And through that Word document, you'll see that some of this is getting at the point of strengthening what we currently do and looking at the various agencies that collect data, how we need to integrate better, integrate data sets better and build on that infrastructure. So it's getting at what you're talking about, Dana, and it should be explicitly identified in that report.
Stevan, I see your comment that there's a difference between what is reported to the state and what is reported publicly, and that there is not that much publicly available information about assisted living facilities.
I would say very little.
Yes, there's very little.
Very little. Blue rates.
Right.
Dana, I see that your hand is up. Her hand is down.
Okay.
And Rebecca is pointing out that item number 5 in the draft report focuses on what would be publicly reported.
Thank you, Rebecca. Okay. Are there any other comments for this one? Okay, let's move on to number 3. I also want to point out that you can send me detailed feedback later if you need the chance to process any of this further.
Yeah, and I would encourage you to look at the recommendation document.
Yes.
Not just the PowerPoint. That I think that
Yes.
you may have comments on the text, and it'd be helpful to get that feedback as well without sort of the top level reaction to the recommendation itself.
Yes, thank you. As both Ben and Rebecca pointed out, there was a text document sent to you, so make sure you utilizing that as well. Okay, so recommendation number 3, develop a strategy to ensure availability of deficiency reports for a public reporting process, public reporting purposes. So right now, deficiency reports aren't easily accessible, and we'd like to develop a strategy to make sure that they're easily accessible and we can use them for public reporting.
Dr. Nay, I see your hand is up.
Sure, I just want to correct something in the Word document under number 3, the first bullet point. It says the state should develop clear guidelines outlining the process for preparing and redacting statements of deficiency, and it should specify what needs to be included in the statements, as well as the necessary redaction protocols to protect sensitive personal information. That's not correct. The state already has a well-established process for releasing documents through the Maryland Public Information Act. Staff undergo training. There's manuals that are hundreds of pages. Staff get refresher courses yearly, and additional information is given from like the Ombudsman Office for PIAs. So there's already a process in place. Everyone's trained, and we actually at OHCQ produced more than about 70% of the PIAs for the Maryland Department of Health come from OHCQ, and we generally are producing them more timely than other agencies and being responsive. So we are producing what we're asked for. So I just ask that you look at that first bullet point to make sure it reflects the accurate situation.
If I could just say.
Thank you.
Jana, did you want to say something?
Yes, because, and I'd have to double check the regs, but I do think that the assisted living programs have to post their deficiencies or make them readily available. So I'm just a little bit confused at what this is also trying to gain. And I do think that they're posted, correct me if I'm wrong, but on the Maryland Healthcare Commission's website, or I mean, I know they're posted somewhere.
Correct, that those that are for 10 beds are posted. There are some, limitations with that, but you're correct. And one of the comments we've heard over the years, especially among those facilities that are kind of fall in the under 16 beds or fewer, is no fair, that the Healthcare Commission posts the results from the survey on our quality reporting site, including links to the deficiency reports compiled by OHCQ. But if you're under 10 beds, because we don't survey those facilities don't have deficiency reports posted on the MHCC site. I realize there are other ways to get to that, but the objection, is that it's kind of nice to go to a site where you can pull up, all the results in a given jurisdiction, but you don't see the under 10 bed facilities, which is, especially for those that have a less than fully favorable report. The point, the objection I have gotten over the years is, well, my competitors are even, worse, and there's nothing here to convey that to consumers. So I think, when we think about this, we want to focus on a consistent platform for reporting information that recognizes smaller facilities. We're going to have to report less, but the ability to access deficiency information from a common quality platform, as you're able to do for all nursing homes, all hospitals, all ambulatory surgery centers, would be a aspirational goal for assisted living as well.
So just to clarify for this one, so because MHCC doesn't survey any facilities, that is OHCQ. So it's the OHCQ survey and deficiency report that's linked on the Maryland Healthcare Commission's website for 10 beds or more. So you're looking to apply that requirement to 9 beds and under? Is that what you're basically saying? Or to have an entirely new platform? And the other comment that I will make, and we have been asking for this for many, many years, if you are going to post deficiencies, it is only fair to post the plans of corrections and the responses from those communities, because oftentimes you have a deficiency, and if you look at it, the way it's worded is a lot different than the actual situation and then the plan of correction. So I think if you're going to do that for transparency, you have to have both.
Yeah, I think that Stacy's going to speak to, but I think that's a good suggestion, and the corrective action plan, if it's been completed, typically
It has to be completed. Yeah.
that we would post that information as well.
Yes, as for your first question, I believe you were asking if we're trying to apply the same requirement to the smaller facilities compared to the larger facilities. Yes, we would want to, we're trying to have public reporting across the board for all assisted living facilities, if that's what you were asking. And yes, the plan of correction is an excellent suggestion. Thank you.
I wonder if Dr. Nay has any concerns about posting the plan of correction in addition to the deficiency?
She agrees. Yeah, Dr. Nay put in the comments that she agrees that a statement of deficiency, if the statement of deficiency is posted, the plan of correction should also be posted.
Thank you.
Tracy DeShields, I saw that your hand is up.
Oh, it was. I just wanted to point out so that the term survey used by MHCC is very different than the term survey OHCQ. And I just wanted to make note of that so people understand that.
Yes, that's a good point. When we're talking about, when Ben was talking about surveys, he was talking about questionnaires. Sorry for the confusion. Are there any other comments?
We have two other people. We have Eileen Bennett with the Ombudsman Program and Ruth Fishman as a small assisted living provider, both agreeing that they would like to see the plan of correction available. So
Thank
do
you.
we have anyone disagreeing about that?
Okay, thank you. Let's move to number 4. I don't see any comments. Number 4 is to conduct a thorough reassessment of so this is for Medicaid, conducting a thorough reassessment of reimbursement policies in the Medicaid and home and case waivers program. This is coming from the fact that we got a lot of feedback from the provider survey that they don't feel like they're getting enough reimbursement for their services and enough types of reimbursement. So we are suggesting a reassessment of the policies to see if there's any updates that could be made.
Just as an FYI, so we don't recreate the wheel, in I think it was 2018, Hilltop did a very comprehensive survey which indicated the disparity between the reimbursement levels and the cost of care. There had been, and there is some budget language this year that's very broad, but just so we don't recreate the wheel and have additional costs for the state, I think that just updating that Hilltop study will get where we need to be on some of this.
Thank you.
Good suggestion.
Great suggestion.
This is Howard. I'm just a question. Is this only get to the existing program and reimbursement levels, or does it also look to examine the implications of the federal home and community-based services waiver requirements that are being pushed down to the various states that, to my lights, have a very negative effect on the availability of assisted living facilities able to participate in the Medicaid program? But is this only talking about kind of sufficiency of reimbursement for under the current program, or because I know there's an effort underway to address the needs of the federal requirement that's coming down the pike?
Well, this was for the current program. We're aiming to reassess the current program.
We can incorporate.
Yes.
Yeah, I mean, I think, I don't know that we have any, Medicaid has seen this, recommendation. But I don't know how much they thought they put into it. We would definitely, this recommendation, needs to be refined in collaboration with the Medicaid administration. Because a lot of this will really entail the activities surrounding program operation and administration.
Is Courtney on the phone?
Yes.
Yes,
Part-
I'm here.
Do you have any comments about this one, or do you want to submit further details later? or-
I mean, this would most likely, because that would be out of me and Lisa's control. We would have to speak with Marlena Hutchinson, and then she would have to take it to the secretary for it to even be looked at. I know providers last year got a 12% increase, which was pretty sufficient. I know in past meetings, you guys were looking at possibly having different rates for different areas, because the cost of living may be higher in some counties than other counties. But that would be something that we would definitely have to take back to administration to have them look at it.
Okay. Thank you.
Dana, I see your hand is up. Okay.
Is there another
Her hand
chat?
is down. Estevan, I see that you commented that your office would want to get input from the Medicaid waiver program. So thank you for that comment.
Any others? Okay, let's move on to number 5. The 5th recommendation is to collaborate with the assisted living industry to develop a public education campaign about assisted living as a long-term care option. So this one is, I think this one's fairly straightforward, but it's for the state to collaborate with the assisted living industry. A lot of the providers on the provider survey felt like they could use some help getting the word out there about assisted living and having it as a viable option. And that's one of the things that we aim to do on our Maryland Quality Reporting website, is to get the word out about assisted living. But we can always do more. So we are proposing to do more. Sir chat.
And Dana, I see that you put in some of the actual numbers for the rate increases that are coming up at the end of the year and then following. So thank you.
And everyone should be able to see that in the, if you go to your chat.
I believe so. Yeah, the home and community-based services in actuality will only be receiving an 8% rate increase because the federal ARPA 4% ends June 30th and is replaced with the 4%. Therefore, its a net effect is an 8% increase.
Thank you. Are there any comments on the public education campaign?
This is Eileen. I'm sorry, I can't raise my hand. I just really want to hit home the point that if in the assisted living realm, the levels stay as they are, and of course, we don't know what'll be coming out in the next comment period about the regulations, but there is a lot of consumer confusion about what those levels mean, and understanding that level 3 can go as high as someone who's in a nursing home setting. An education around what that truly means. Now, I know that it's sort of defined, but it is not well understood by the public who is looking for services. So I'm just suggesting that piece of it be expanded if levels stay within the regulations, and they may or may not stay that way. So I don't want to belabor that point. I just want to kind of put a little asterisk next to it.
Thank you.
Thank you.
Search out.
Rebecca was just posting the topic.
And that's being shared with everyone, not you, just, is that correct?
Yes, it's in the chat.
Okay, thank you. Any other comment? Oops, sorry. Any other comments before we move to 6? Okay, let's move on to number 6. Number 6 is to develop and implement a phone application or website portal for assisted living program data sharing. So this goes back to our desire to gain some information from assisted living programs so that we can share the data, we can use it for public reporting. And this could be as simple as a phone application or a portal that data can be implemented. If you look at the text document, you'll see that we are proposing to start the rollout of this with something very simple, which would just ask assisted living programs to submit basic information about themselves. And then we have a couple of phases to make it even more integrated and more useful over time.
So I could imagine that we would scale this by 5 to 15 beds for that mid-size as well. That biggest challenges with the current MHCC web-based survey is gathering information for facilities, as I mentioned earlier, kind of around the range of 10 to 15 beds. And many of them are not really configured to have a data reporting person dedicated. And I think this gives us an opportunity to scale it under 5 and under 6 to 16 and 16 and above. More than anything else, I'm thinking here as I'm sitting down, but it would be, I think, appropriate if we want to capture information on the industry that we think in terms of categorizations that OHCQ uses as well.
Yes, thank you.
So, Dr. Ney has put a comment in that perhaps MHCC should sign a data use agreement with OHCQ to get basic assisted living provider information so that providers do not need to enter it into 2 systems.
I think we're working on that right now, Dr. Ney.
And
I agree, we don't want duplicate data entry.
and Deanna's hand is also up.
Yes, thank you. And this one actually has me perplexed because I'm not exactly sure how this would differ from number 2, because number 2, why it's a feasibility study, it's on the collection of data. This one looks to be the collection of data as well. And I think when you say a phone application, you're not referring to the licensure application, but I really don't understand what this one is trying to get at, given that you've got the data infrastructure to collect assisted living program data. Under number 2, this one just seems like, again, it's a repeat of information that's already out there and putting another requirement on assisted living providers that I have a hard time seeing where the benefit is. It's easy to say that you want more data, but I'm not sure exactly then how is this differ and where is it already being reported?
Teresa.
So these 2 are definitely related. This, the earlier, I think it's number 2, talks about building that data infrastructure to collect the data, and then the agencies sharing that amongst themselves, and then with the public through public reporting in our case. And then this, what is it, number 7? 6, I'm sorry, gets at an alternative in that data collection infrastructure that we're thinking about building to maybe try to, as a pilot, on a pilot basis, have a way for the smaller assisted living facilities to go to, through a link to a website to enter certain information, confirm information, or the other possibility is to have something like a phone app, because we hear that they're very small. We understand they don't have the resources with data people. So if we wanted to collect some information on staff that may not be elsewhere available, if we wanted to get some staffing satisfaction data or operator satisfaction or concerns, or just begin to pull more information and communicate electronically with the smaller facilities, this is tailored to the smaller facilities with less resources. But they are definitely related and they're not duplicative. It's just sort of pulling that out to show this is another way we can get data in addition to building on the current infrastructure we have.
Rebecca?
Thank you. I mean, Danny, you bring up a good point. We don't want to duplicate any data, but data collection purposes or multiple recommendations. But Teresa brought up a good point. They really do have kind of two separate purposes. So if you look at the Word document for item number 6, it's a lot more into detail of meeting the requirements that were part of the legislation, where it really wanted to address how can we, for example, with phase 2, focus on what we could do if we had another public health emergency. How could we collect data in a timely manner to be able to understand where there are opportunities for us to intervene? Are you really adhering to the different regulations that are happening for like a mass infection or spread of some other future disease? And even in item number 4, phase 4 of the project, which is one of the things that we also wanted to address, that does come directly from the public health data now, the survey analysis we did for small facilities, where we know that there's an issue with small programs not having high rates of deficiencies for not having good emergency management plans. So for example, if there were a house fire and what happens to the patients or the residents, how do you share that information back and forth? So we were really kind of looking at it through 2 different lenses, but there would be an opportunity to potentially think about what you could harmonize from incorporating some of this into a feasibility program. But that's kind of how we were looking at it initially, to just kind of put it out there to get everyone's feedback.
Well, let me ask you this then. So you mentioned phase 4 and it says assisted living programs will be able to access, update, and transmit emergency and disaster plan information, including resident tracking and medical fact sheets through the application. If that's a phone application, just give me a scenario, like how would that work? I am an owner of a 5-bed and I just had a fire. So what does this phone application do for me now? Or what do I have to do for it?
So actually, one of the deficiencies was just having availability of an emergency management plan. So in the case of a fire, what do you do? Where's all your resident information stored? How do you know who to contact? So for example, if you had a house fire and that information was reported only in like a physical file in the residence and it burns up, how do you know how to contact all of your families? So this would be a way that potentially that we could push information out to family members in the case of a fire. We haven't really gotten into the nitty-gritty, Dana, exactly what that would look like, but it's another opportunity for us to be able to do that information, to share it not only with family members, but also potentially even get it into emergency response providers to get them the information so we have medical records. So we're kind of thinking about the best way that we could do this, because one of the issues that we saw is that patients would, I mean, I hate to say, or residents would get misplaced or move to different programs, and then they wouldn't know where to follow up with them, or they wouldn't have their appropriate medication list with them to make sure that they weren't going to have a complication because they weren't taking the right meds. So that's kind of what the thinking was behind this, how we operationalize it. Not quite there yet, but I think there's a really great opportunity here to do something with this.
So it sounds like you're actually saying that because I mean, we have regulations that require certain that have certain requirements for fire drills, emergency sheets, all of that. So it almost sounds like you want all of that uploaded to like a cloud system. So maybe you saying phone application isn't the right terminology for what you're trying to get
Yeah,
at. To
we-
me, it
we
sounds
toyed
like you
around.
want it
I
We
think-
offsite.
sort of- Yeah,
Yeah, I think we're talking about a phone app as opposed to, maybe just the sequence of how you say by phone, you're thinking of it.
yeah, it's
In
not
a
phone
different
calling.
way.
That's what I initially had thought too.
Yeah,
when we
it's
were
not a phone
discussing
call.
this.
It's not a
Yeah.
phone call.
So
We're
it's
not
a
doing
No,
data
you-
application,
you
like, but
yeah,
something
data.
that's up on, like your documents are someplace else, like on the cloud or something like that. Is that what we're trying to do with all of this?
Like a web-based application, put it that way. That was the thought with this. There's a way to ease the availability of this information so that patients get better care and that we don't end up not having the right information with the patient. It could enhance data sharing, streamline reporting processes, improve transparency, and then, I mean, it could potentially also enable better oversight of the regulatory, of the assisted living programs themselves.
Yeah, and to the point about some of the members observed that 2 and 6 seem to be duplicative or contradictory in some ways. I think we'll look at those two together. Certainly they need to be moved together in the recommendation sequence, because we probably want to put an overarching framework on the recommendations, those that require further data collection or data integration should all be put together. I can see, with 6, there's also a planning process that's implicit in this. We're just not going out and announcing to the industry that this is what you're going to do. We would plan to have work groups to discuss the perspectives of the agencies and what they think is appropriate and doable, which does seem kind of like certain elements of 2 also trickle into 6. So I think in terms of the sequencing of the recommendations, simply reordering them could add some clarity.
Thank you.
So Dr. Nate has her hand up, but she also has the comment or the question, what agency would be collecting and sharing this information? So Dr. Nate, if you'd like to speak.
Thank you. So Rebecca, can you speak to, I'm not clear, like if there's an emergency, the ombudsman and OHCQ are often both there and involved. So is this somebody else they're reporting it to? Who's sharing it? Is the assisted living going to have to now communicate with some other entity? But can you explain in practice how that would look?
Sure, I'm happy to. So we talked about this as in the concept of it being an app, and we haven't, as I mentioned, fully operationalized what this might look like, but as a way to have an additional way to share information that's going to be available in the case of a public health emergency, and that information could be made available. So to the point that Dana made earlier, would this look like a web-based, cloud-based solution that we would upload information to? I think that is one aspect of it. How it would or could it interact directly with emergency providers, that's a potential, but maybe it's not even feasible. Really trying to think though how we can streamline how this information is recorded and where it's recorded, because as I mentioned, we did see quite a few deficiencies that were shown in the data we did the analysis on, that this was a significant issue. It was in the top 3, I believe, issues for the small assisted living facilities that we looked at. So what could we do to make it easier to have this information readily available so that we don't have potential patient harm or things like that? So as for your question about interacting directly with EMS or groups like that, that's a pipe dream, I think, if we could have a harmonized system that could help with a lot of that. But I think it's a start just to have the information up and available more readily so that we can have the necessary information that goes, the medical fact sheets, that's what they're called, I blanked on the name, to go with the patients to make sure they're getting care in their new program while they're displaced. Does that answer your question?
Thanks, Rebecca. I would ask, the period of time where you saw more emergency preparedness deficiencies, was it during the COVID pandemic, those years?
It was before and after. So we didn't include 2020 in our data analysis, so it was 2019 and 2021 that was included in our data analysis. So kind of right before and kind of quasi after, depending on when you think it stopped.
Okay, thanks.
Eileen Bennett has the question regarding, are we looking at a central registry for residents? And she has a comment about a recent simple disaster was the ombudsman went into a small assisted living facility that had their electricity turned off for non-payment. And the caregiver did not even know where the resident was currently at a medical day program. So she's pointing out that we might consider the operations are more advanced than they actually are. So thank you for the ombudsman perspective, Eileen.
Are there any other comments?
Yeah, I mean, we haven't talked about this, but clearly as we move towards operationalizing it, and whether it's I mean, I think we're talking about a web-based application that is accessible via a phone app, whether the cloud is a entity that would pass through the CRISP infrastructure or be completely independent, perhaps developed under MD Think. We're at a very, very preliminary stage, and we're not really equipped to spell out the entire technical stack that would have to be put in place. But simplicity would certainly be, I think, an important design principle that we want to make sure about this. We did learn, I've participated on many of the data integration efforts throughout the pandemic, and simply getting vaccination rates, et cetera, was really challenging. So we need to keep that in mind as we consider this, that the ability of organizations to respond even to what we would consider basic information will have to be carefully nuanced.
Dana, do you have your hand up again?
Yeah, I did. And I don't mean to jump ahead, but I do think that this is connected. It is a bit ironic that in recommendation 6, we're talking about assisted livings having some type of web-based application or reporting to the cloud. But on number 10, we're saying that they all have to maintain a valid email address and have internet access. It seems that if we're at the stage of having to require them all to have an email and then jumping ahead to a web-based application, that might be something way down, but I don't think it's realistic to have a report that has those two things when they are so far apart. So just an observation.
Sure. As I said, I think we look at how we make the data, the recommendations on data, at least bringing them together. But, we certainly are going to look at what might be a little bit incompatible among the 3 or 4 that relate to data collection, data reporting.
We only added that one in because it's not required. It says it's highly recommended in the OHCQ app, I believe. So we just wanted to emphasize that and have to remain there.
Chat.
Nothing else in the chat. Dr. Nay, I see your hand is up.
Yes, thank you. So just to clarify, for assisted living providers, what we've done is we have provided simple forms that you can fill out online on any mobile device for things like resident specific waiver, your a name change, but not a sale or shall or relocation, for a personnel change, a change in your email address or other demographics. So we've put those forms out there so people can fill them out. Many of them are designed with not a lot of data entries. So they can do it from their smartphone. So that makes it easier for them to provide the information to us. So that's when in previous meetings, when I talked about that, that's the way that the kind of system I was referring to, not something more robust, like collecting lots of data. I think, as Dana said, my challenge is to, when we need to send out emails to assisted livings, more than once, my staff has had to call, the assisted living programs to find out their current email address. There's over 1,700 of them. So we're trying to make it very easy for them to just maintain their accurate email address with us. And I think that with the assisted living managers falling under the Board of Examiners of Nursing Home Administrators, that perhaps we'll have better email access to them. So I think that would be a good outcome of that new requirement.
Thanks, Dr. Name.
Catherine Victorine has pointed out in recommendation 6, she would recommend altering the language for that recommendation to simply say app instead of phone application, as there are two different meanings. The app would be used to develop on a mobile device versus an application is considered to be software. So thank you for that distinction.
Thank you, Catherine.
Yeah. Stevan has another comment regarding the providers providing the accurate contact information, and that most providers do have cell phones, but the difficulty of keeping their contact information up to date. So I think that OHCQ, MHCC, and the Department of Aging all have that same concern about keeping current contact information.
All right, thank you. So number 7 is enhance assisted living program owner and staff training programs and resources. And number 8 is very closely related to develop programs and resources to engage and retain assisted living program staff. So overall, from our data analysis and our research and from the assisted living provider survey, we found that there was a definite need for owners to have training from business to regulate the business, how to run a business, to how to navigate the regulation system. And they wanted more programs to help them train staff, and staff wanted training of their own. Also, there's a lot of concern about engaging and retaining assisted living program staff. So we are proposing more programs and resources.
This is
So the
Howard.
problems.
To Dana's point earlier about the distinction between small and large programs. I mean, are these examples of things that you're thinking of doing that apply to very large programs or small programs? Because the scale, scope, and nature of these is radically different if you're talking about less than 10 or more than 50.
We found that this was a problem across the board, so this is a recommendation for all assisted living.
But to the point that Howard made, I think these initiatives would be scaled appropriately. There's some aspects that would be cut across the industry, and some that would be specific to the small and medium-sized facilities only. But I think it's hard to characterize each of those bullet points as to whether you would have 3 programs or 1 program that would be only open to medium and small facilities, and assume that larger programs could either conduct this type of work themselves or may not be interested.
Dana, you have your hand up.
Yeah, so just as an FYI, so you said that these were applying to all. In legislation last year, there is a big change coming to the entire industry in 2024, which has not been said in any of this report, but assisted living managers will need to be licensed under the revised BENHA, Board of Nursing Home Examiners, is going to become the long-term care board. And all assisted living managers will have to be licensed by that board. So one, you have more accountability, but also within that legislation is the fact that those 5 beds or fewer assisted livings with a manager will have to take the manager course, which is an approved course. The subject is in the statute and the content is approved by OHCQ. So a lot of this that you're seeing right here is actually going to be required as of October 1st, 2024 for those small providers. So I think that is also important to recognize in this. I do think that this becomes more problematic when you are applying it to all, especially since, again, the legislation was for the small providers. And we did have that legislation. So I wanted to comment on that. But, you know, one of the things that the legislation required, which is nowhere in this report, and I think that's a disservice, is it required a review of the current assisted living licensure requirements to determine whether these programs should be regulated differently than programs with 10 or more beds. And this report, and it seems like the work group hasn't even taken a look at that, which was mentioned during this session. Delegate Riley actually brought that up in the House Health and Government Operations Committee. And I think when you're looking at all of this without also looking at that, given the fact that so many of these small providers, one of the biggest issues is we have a one size fits all, that if you're only taking SSI or some type of other assistant programs, that's a big difference than the facilities who are taking $6,000 a month. So I didn't see anything about that issue. And I think that is problematic when you're looking at all of this training. And then my last point is on the next for staff training. I think we really have to take a look and remember that we have a whole commission that is taking a look at training and staff and the workforce crisis. And that that includes those that would be employed under assisted living and all the programs that are being looked at now by the Workforce Investment Board. So those are my points.
Thank you, Dana. Stevan, you also have your hand raised.
Yes, I just wanted to say that, and by the way, I'm so glad we're discussing all of this. This has been very good, by the way. But I just wanted to say, as far as the education and training, a lot of the problems that we see in all sizes of assisted living have to do with training. The problem wouldn't happen if the person either was trained properly or had a refresher. All sorts of complaints all across the map, all different sizes. So I just wanted to say, from the ombudsman perspective, I think that looking at this for the small and larger assisted livings and taking into account the staff that work in each setting, as Dana mentioned, will be very helpful. The larger assisted livings actually have, for different reasons, have a lot more internal support than the small ones do. So even though they take, they charge more, but they also pay more for staff. So I think it's interesting to keep that in mind, but the need is the same. The staff need to know how to take care of the residents that they accept. And if they don't know how to take care of them, they shouldn't accept them. And so they need to, when they admit somebody that has dementia or substance use or mental health issues, or they just they're recovering from an illness, or they have, they need assistance with just activities of daily living, they need to know how to take care of people and have appropriate training regardless of the size. So I just wanted to reinforce that number 7, I think that needs to be looked at very closely. And again, I don't mean to be redundant, but taking into account the staff that work in each of the settings. Even the small ones where there's a better staff ratio, those staff still need to have good education so they know how to take care of somebody that has dementia or whatever the reason that causes them the issues that they have. So thanks.
Thank you.
Thank you, Stevan. Eileen Bennett has a comment regarding the ombudsman's visits with the smaller homes, that they find that the smaller homes are caring for some of the most complex care, and that they need the training that the larger assisted living facilities get as well. She also points out that some web-based training as well as on-demand basics would be a good start. So thank you for that, Eileen. Rebecca has her hand up.
Thank you. So Dana brought up a really good point about the manager's training that's going to be required starting next year. And if I'm remembering correctly, doing the literature search and talking with some of you all, as well as doing the survey, doing the analysis there, that there's a lack of sufficient manager training courses really to support that training that is going to be needed next year to help with the licensure as the requirement for the board. So I'm wondering if anybody else has any feedback on what is the state of manager training courses. I believe it has to be like a standardized or approved course. So correct me if I'm wrong on that one, but just wondering how or if we could potentially get more feedback on what your perspective is on that to make sure that we have enough courses even available that are approved to meet that need moving forward.
Dana?
Tricia had Dr. Nay had her hand up first, so she might want to comment, and then I do have a comment to Rebecca's.
Okay, I didn't see that. Sorry, Dr. Nay.
Thank you. So in regards to the vendors, Rebecca, I just put a link in the box. There's 5 pages of approved vendors. I don't know how since I don't know the capacity, and Dana, maybe the industry has a better sense of this, but before we say there are not enough approved vendors, I don't know what their capacity for training is or anything. So but I threw that out there. So that's located on our website, so everyone can look at that. Just as to digress back on one of Stevan's points, while OHCQ does cite the lack of fulfilling all the training requirements, the bigger issue is not whether they've been trained or not, it's whether they've implemented it and they're being held accountable to do what is in the policy or the procedure or what they received in their training. So it's really whether they can effectively translate their training to good quality care, which is what the bottom line is. So many of the times when we cite training, there's no outcome associated with it. So we may cite three ways that their staff aren't trained. Then we may cite 5 deficiencies. None of them relate to the staff that weren't trained in those areas. So more often than not, the deficiencies are related to staff who've been fully trained, completed all the requirements, but either for whatever reason didn't implement them and it didn't translate to good care.
Dana?
So for the assisted living manager, there was a comment in the chat that requirement is October 1st, 2024 for all managers to become licensed by the board. That process hasn't started, and I think that the board is in the stages of even developing that process for any assisted living managers or representatives here. We still have a long way to go to get to October 1st, 2024, but that also does require those managers to take the course. Now, I think one of the issues that the state needs to take a look at, and I know that the Beacon, that's Lifespan's educational affiliate, offers that course. They've offered it since the beginning of the requirement. but there's a cost factor. And I think that the state might want to take a look at how does it help or, provide grants or some type of funding or subsidies for these assisted living managers who now have to take this course, who have never taken it before, to be able to do that. So Dr. Nay just said, what is the approximate cost of the course? It's 80 hours. I can get that information, at least on what the Beacon charges. In my head, I'm thinking it's anywhere from 1,200 to 3,000, but nobody quote me on that. But I'm more than happy to at least find out what the Beacon charges for it. But 80 hours, it's a comprehensive course.
This is Howard. Could I just build on this point for a second? There's a big difference between requiring training and paying for training. When you're dealing with these small homes, as Dana said, they're lucky to get the Social Security money, which is offsetting Medicaid. The margins are extremely thin. The resources, these are things where the margins are thin, the resources are small. If you're going to require training that they're going to have to front, you're going to be pushing people out of the business. So the question is whether or not there's an investment in scholarships or for people who are managers of homes of a certain small size to not just impose a requirement, but also provide mechanisms for people to have updated information. There's some of them can't afford dues to member associations, so one of the long-term care associations or one of the two national associations, or they just don't have the resources to plug into the training and informational resources. So one of the things that really could come out of an exercise like this is something that says, how do we provide resources for people who are in operating these smaller homes to get the training because they provide a necessary service, as opposed to just imposing an additional requirement, even if it's an adjusted requirement.
Thank you. That's an excellent point. Rebecca, you have your hand up.
Oh, no, sorry, I never put it down. Sorry about that.
Oh, okay. Okay.
Deanna, there is Stevan was asking if the law related to the assisted living managers being licensed in 2024, could that be sent to the group? And I'm wondering, I'm trying to look it up on my phone, but do you have a link to it handy? I'm assuming it's under the Board of Nursing.
Board of Nursing Home Exam.
Right, under the
Yeah, sorry about that. It was legislation put in. It was sponsored by Senator Kelly. I can put the link in.
Thank you so much.
Are there more comments?
Debbie Gallagher, thank you for looking that up. The Beacon 80-hour course costs $1,550 currently.
Okay. Are there any further comments on either 7 or 8? Thank you. Number 9, identify funding to support enhancement of the long-term care ombudsman program for assisted living. Rebecca, would you like to add anything about this one before we ask for comments?
Sure, I'm happy to. So we looked back through some of the initial discussions that we had with Stevan early on, looking to try and figure out how we can continue to support the ombudsman program. So we know from previous conversations that the ombudsman are going through a regrowth time period after the COVID-19 pandemic, trying to get sufficient volunteers, but they do have a wide range of geographic area that they're trying to cover with limited staff. So we do know that they do a lot of really good work. They help, really be the advocate for the patient, really taking their perspective. And so what can we do to create a more holistic way to involve them and work with them? And I know Stefan's got her hand up, so I'll let her speak for herself, but really be more mindful of working with the ombudsman, with OHCQ, with MHCC. So we have a really collaborative process that is really advocating for the best interest of the residents themselves and their families. But I'll yield the floor to Stefan because I'm sure she has a lot of great feedback on this one.
Yeah, and I definitely will provide feedback on the comments in the Word document. So thank you for putting that together. We actually have a very robust training. So the comments about training in that document actually will want to revise. Our training is mandated by the federal government. And by the way, there's a mention about Maryland Department of Health towards the end of those comments. I just want to make it clear, we're not part of the Maryland Department of Health. We're separate we're Department of Aging, but the Ombudsman program is independent within the Department of Aging. So the training and the requirements of the program for certification and designation of staff actually is between the state ombudsman and following the Older Americans Act and the ombudsman regulations. And we have and I'm happy, by the way, to talk about any of this at any time about the detailed points that are brought up in the comments that they put together for this draft report. The main thing we need, honestly, is our funding for the ombudsman program has been level. And because we have so many assisted livings, and I mean level funding at the state and federal level. And so one of the things I'm trying to do is to try to increase that. We have a new administration, so there's a budget process, and Dr. Nay knows more about this, and MHCC knows a lot about this too, of course, about how that budget process works for state agencies. So that's something I'm working on. We're also looking at how we fund by county. There are counties that put money into the ombudsman program, and I'm very grateful for that. So we have a process right now called area plans, which we're looking at. I'm looking at the budgets for all 19 area agency on aging for the ombudsman program and seeing if the budget, both state, federal, and county, meets the needs of the ombudsman program. In some counties it does, and some it does not. So, but mostly we do need more staff and more volunteers because we have so many assisted livings, and our goal is to visit assisted livings without a complaint at least quarterly. Our goal for nursing homes, by the way, is monthly. And then if we have a complaint, we go out fairly quickly, usually within a couple of days. So we just, unfortunately, the funding for assisted living, because we've had level funding for so long, we do need more staff, especially to be able to visit assisted livings in larger jurisdictions, especially more often. And that would help us have the residents are required to have access to the ombudsman program. And that's the point of our visits, to let the residents and the facilities and the families know that the ombudsman program exists, and also to look at quality of life and quality of care from an advocacy and a resident-centered standpoint, not a regulatory standpoint. I'm going to definitely look at the report draft recommendations and make some feedback. And by the way, always open if there's an area that we can do a better job of. Happy to look at that more closely, but I think our training actually is very sound and very good around assisted livings. And then we tailor our work based on individual needs of a given area or even a given facility. So if you have any questions about that, let me know. I know I tend to go on and on about things.
Thank you, Stefan.
Dana, thank you for sending the information with the link to the legislation. And Dana has pointed out that the page 2 and 29 of the legislation shows where the small managers having to take the training is the result of the changes on those 2 pages. And then page 10 is the requirement for everyone to be, or all assisted living managers to be licensed by the board. So Dr. Nay, I see that your hand is up.
Thank you. I just wanted to caution folks about the unfunded ideas that have been put out there in this report. So whether it's MHCC, OHCQ, or the Ombudsman, or others, or Medicaid, we, as Stefan has talked about with our budgets, we have a set amount and already have, all of us have mandates. So something that we all, I think, we're generally agreeing with, like publicly posting statements of deficiency and plans of correction. My budget's about 31 million. I I'm only guessing $4 or $5 more million in additional staff to do that. So while I agree with that, I think we need to be mindful of like who's going to do this. I mean, if, for instance, Ben, if I turn over all my redacted statements of deficiency and plans of correction to you, is MHCC going to develop the IT infrastructure to post them in a user-friendly way on the MHCC website? So I just think we ought to, I'm not saying we shouldn't aspire to some of these, but we just be mindful of that there may not be funding for these.
Thank you, Dr. Nay. Yeah, I mean, I think we would anticipate that if we receive this information, we would be responsible for developing the infrastructure to display it in a useful way. We haven't looked at what that would actually cost. IT development in some areas has actually gotten cheaper as the knowledge base of who can do it has broadened, but it's difficult to predict, you know, today, right now, as we preliminarily look at this, what it would actually cost. And it's appropriate to be somewhat cautious.
Thank you. We will keep those in mind.
Stevan also made the comment that the state ombudsmen across the country are looking at an increase in federal funding as well. Stevan, I see your hand is up.
I can't type today. I apologize. I read that and I was like, that's not exactly what I meant to say. So that's kind of funny. What I was meant to say is the state ombudsman across the country, there's one in every state, and we are trying to get more federal funding. So there's no guarantee that we will. There's money that's proposed in legislation federally, but that's happened before. And in some states, our federal funding is very small. It's based on a formula. We get less than $400,000 in federal funding. So, so we're grateful that we have state funding. We're grateful we have county funding, but I just wanted to let you all know. And by the way, our budget information is public as far as how much we get from funding sources and that sort of thing. So if anyone is ever interested in that, I can show you. And actually, if you want to look at other states across the country, it's available about all the states across the country. So it's interesting to see. But the problem, as Dr. Nay and others have said, is that I think we all would like to do more, but the issue is has a lot to do with the fiscal implications of what things cost, and so I think all of us try to do the best we can with what we have. But my goal is to continue to ask for money for the ombudsman program, and I will make comments for this draft to reflect that, and definitely look forward to any feedback you have about those comments.
Okay, let's move on to the last one. We've already started to touch on this, but as Teresa said, the application strongly advises each assisted living program to have a valid email address and internet access. We would like to propose requiring these two items to make it easier to implement a lot of these recommendations. Any thoughts? No? Okay. Well.
Looks like Dr. Nay's hand is raised.
Oh, yes, Dr. Nay, sorry.
Thanks. I would just like to say that this is one of the most important recommendations on here that we could implement, and we're doing everything at OHCQ possible to communicate via email and checking, sending out periodic emails when addresses kick back, calling people, getting folks in the habit of using email as a way to communicate. But this not only benefits the assisted living and OHCQ, it benefits the ombudsman, MHCC, Medicaid, that we all have a way to communicate with them. That would make the processes all easier. So I'm very much in support of number 10.
Thank you.
Yes, Stevan also agrees with Dr. Nay, and MHCC agrees with Dr. Nay.
Any other comments? Okay.
Ju-
Go ahead.
I was just gonna go back. I had texted somebody, just going back to the manager course, because we were talking about availability and access. The Beacon, they hold it now about twice a year, sometimes 3, but it really just depends on volume. So again, it is one of those issues with more now needing to take it. They do have the capability to offer it more. So just wanted to point that out.
There are no further comments. We can go over the next steps. So first of all, if you would like to submit written feedback, are there more chats?
Ruth Fishman would like to know, does anyone know the qualifications of being able to teach the assisted living manager course? And then Dr. Nay has a question. How many participants can be accommodated in the Beacon training? Oh,
For the Beacon course, I can get answers to both of those and let you know.
thank you, Dana. And Dr. Nay is asking Ruth to please follow up with Dr. Nay after the meeting. So let us know if you need her contact information.
Thank you. So if you would like to submit written feedback to our recommendations, please do that. We would love to hear your feedback. And next Monday, I think we would like to have that by, so that we can begin working on the full report. And we'd like to incorporate your feedback.
Well, that would be Memorial Day.
Oh, sorry. Okay,
We want to move it a little bit further, maybe midweek.
I'm sorry, midweek.
Midweek.
Okay, how about Wednesday? Let's do Wednesday then, which is the 30th.
I'm going to actually request a little bit longer, at least 2 full weeks, because again, this report is much, much broader than the charge that was given to this work group, since it applies to all assisted livings, and it's only appropriate for those to have a chance to take a look at, digest, and comment.
Okay, June 5th then. That would be 2 weeks. And the recording of this meeting will be on our website so that you can go back to it for reference. Our goal is to have a full draft of the report to all of you by June 21st. And additional feedback from you by July 12th. And then the goal is to present to the commissioners by September 21st.
When is it due to the legislature? October
1st.
And thank you, Rebecca, for your comment that if anyone on the work group or one of the participants thinks that there are any recommendations missing in addition to what we've already discussed, please include that in your comments.
Thank you.
Anything else, Stacy?
You know, if we need to need to hold another meeting, we will, but right now, this is as of right now, this is the final meeting.
Yes.
So thank you all.
So you would get a draft in about a month if you're not going to comment. But I encourage everyone to do so by the 7th, or June 5th.
June 5th.
June 5th.
Monday.
Which is a Monday. Thank you, everyone.
All right, thank you very much for your participation throughout. We'll look forward to your comments. And we've carefully listened to the comments today, and we'll be making some changes as we noted.
Thank you.
All right. Heading to